भी करेगा वो।
Okay, guys, let's start one by one, and I'm going to show you one by one this couple of things which I would like to ask you personally at one level. If I'll ask you somebody's name, then you have to tell me the answer. Other people will keep their mics on a mute features. First of all, the question goes to Dr. Sumit Chauhan. Tell me
Yes, sir.
important features of cardiac ultrasound waves, Sumit.
सर अगर मतलब एक तो सर उसमें फ्रीक्वेंसी होगा, लो फ्रीक्वेंसी एडल्ट्स में यूज होगा, लो फ्रीक्वेंसी गुड पेनिट्रेशन एंड गुड डॉपलर इफेक्ट, डॉपलर स्टडीज एंड
every question Sumit carries 4 marks. Out of 4, you'll be getting the answer, the marks out of the 4 question marks. Okay, so it could be 4 out of 4, or maybe like whatever it is, depending on your answer.
yes sir.
We'll start with the basic and gradually build up to subsequently. Have you done with your question?
Sir, features मतलब sir किस सेंस में सर? एक
how like cardiac ultrasound makes effects in diagnosis and prognosis?
Sir, cardiac ultrasound से sir what is the difference between high and low frequency transmission? Sir,
no,
high
I'm
frequency.
not asking. No, I'm asking you this question. Give me answer it quick. We can't wait for a long time, you know.
Ultrasound.
Yes or no?
Sir, important feature, I think, sir, that is for resolution and penetration.
The 2 important features of cardiac ultrasounds are wave-wells, 2D and Dopplers. Imaging and Doppler studies.
Yes, sir.
Okay. The next question goes to Dr. Tarun Goyal. Tarun. Tarun, are you there?
Hello.
Tarun, I will not be able to come back again and again.
Sir, I am here, sir. Hello.
Tell me the difference between high frequency, low frequency transducer.
So, sir, if we have a higher frequency, it means that the basically penetration will be low. It would be a very poor penetration, but we can get a good cardiac images, sir. And regarding Doppler, sir, generally we don't prefer in higher frequency. We prefer lower frequency for Doppler studies.
Suppose an adult person is there, which one you will prefer and why?
Sir, we will prefer lower frequency transducer. The reason is that since heart is very close to the chest wall, it's good for the adult, sir.
Heart is not close to the chest wall. Heart is away from a chest wall.
No, I'm sorry, sir. Heart is away from the chest wall, so it's good for the adult. I'm sorry, sir. Just
what happens to near structures?
Sir, it's a poor near resolution is there.
How do you improve it?
Sir, lower frequency will result in so we increase the frequency, sir.
No, we don't increase the frequency. We use broadband transducers.
Okay, sir. Okay.
All right. Let's go to Dr. Amit. Amit, ideal position of a patient in apical and subcostal window.
Hello.
Amit.
Hello.
Ideal position of patient in apical and subcostal window.
Hello.
Amit, are you able to hear us? Are you able to hear, Amit?
Yes, sir. I am able to. Hello.
Now don't mute yourself. Tell me the ideal position of patient in apical and subcostal window.
Sir, it is left lateral position.
For subcostal window,
For subcostal window, it is supine. With pillow just below your shoulder.
index mark for plaques window.
Index marker at 11 o'clock position at plex window.
Structure of plaques from top to bottom.
Structure of plex from top to bottom. No, sir, I don't know.
All right. So the next question goes to Abhishek. Abhishek, are you ready?
Both of them.
Yes, sir.
Normal dimensions of left atrium, left ventricle.
उसका तो संदर्भ है ना?
Atrium, the dimension is up to 39 mm left atrium, and left ventricle in diastole up to 57 mm, and in the systole up to 37 mm.
Normal LV wall thickness.
A normal ventricle, it thickens during systole.
Okay.
The IVS, the interventricular septum, it's up to 11 mm, and left ventricular posterior wall is up to 11 mm as well.
All right. Last question for you. What is pressure? What is volume overload?
Pressure overload meaning when left ventricle try to eject, when there is resistance, it's known as pressure overload. Example would be aortic stenosis. And when there is leaking of blood, when there is more blood, I mean to say,
I got
when
it.
the blood
Give me an answer on right hand side.
of right hand side, pressure overload would be pulmonary hypertension. Volume overload would be any regurgitations.
Volume overload would be?
Regurgitation.
No.
Regurgitation. No.
Volume overload on right side. ASD.
Yes, yes.
Abhishek, you are based in Delhi now or you are in Nepal?
I'm in Kathmandu right now, sir.
Right now at Kathmandu. Good job done. We'll go to Dr. Sumit Chauhan.
Thank you.
Yes, sir.
Don't go away. We'll coming back again and again for everybody. What constitute of ECG in systole and diastole? Sumit.
Sir, P wave denotes atrial systole, QRS wave denotes ventricular systole, and T wave denotes the diastole or relaxation time for both atria and ventricle.
When does diastole starts in PQRST cycle?
Sir, at the end of the PQRS complex.
At the end of?
QRS complex.
When does the diastole starts in PQRST cycle?
At the beginning of
At the end of T wave.
yes, sir.
In which cardiac cycle the various cardiac valves opens and close?
Sir, in systole, the aortic valve and the pulmonary valve gets open, and in diastole, the mitral valve and tricuspid valve opens.
What does Doppler record?
Doppler mean, sir, pressure gradients, mean
Velocity and gradients. Good.
velocity and gradient. Yes, sir.
Fine. Thank you. Let's move on to Dr. Tarun Goyal. Tarun, no, we have done with Tarun. Ravish Sharaf. Ravish, are you there? Ravish. Dr. Ravish, are you there? So we go back again to Dr. Sumit. Dr. Sumit, what is
Yes, sir.
positive Doppler shift and negative Doppler
Sir,
shift?
I am left, Dr.
Yes,
Neha.
sir. When
I'm sorry,
when-
Doctor. Just wait a minute. Sumit will come first. Come to Dr. Neha Goenka.
Okay, sir.
Neha, what is positive and negative Doppler shift?
It is in relation to the transducer. When the blood flow is towards the transducer, we call it, and that means above the line is positive Doppler shift, and below the line is negative Doppler shift, that is away from the transducer.
Example.
When we keep our transducer in the apical four-chamber view, and we see for the flow, mitral valve flow, it is a positive Doppler shift. Aortic flow is negative Doppler shift.
3 important Doppler modalities.
Pulse wave Doppler, continuous wave Doppler, and tissue Doppler imaging.
Color Doppler.
Color Doppler, sorry.
In Doppler study, you should be parallel or perpendicular.
You should be as parallel to the flow as possible.
When do you employ pulse wave Doppler?
For normal flows and I mean anatomic, if the flow is normal, then we use pulse wave Doppler, or we have to quantitate at a
Fine.
particular point,
Thank
then
you.
we use
Thank you,
pulse.
Neha, we got it. So let's move on to Ravish. Ravish is over there. Ravish, are you there or you're still not there? Dr. Ravish. So we go to the second round.
Sir, good afternoon.
Good afternoon. Is that Dr. Ravish?
Sir,
Ravish, tell me, like in recording valvular velocities, where do you put a sample volume? Ravish, are you there?
not clearly audible.
Ravish, where do you put your sample volume in recording valvular velocities? I cannot hear you, Ravish. All right.
Hardly audible.
You please connect your this internet connection is not stable at your end. Please change your internet connection. We'll come back to you later on again. All right, Sumit, you can take up this
Yes, sir.
question. Where do you keep your valvular velocities?
Sir, at the tip of the valves, जहाँ पे सर valve opening होगी जहाँ आएगा वो tip.
How are mean gradients and velocity time integral obtained in Doppler tracing?
Sir, by tracing the उसको सर जो mitral valve जो भी जो ग्राफ आएगा यहाँ पर और नीचे साइड में उसको ट्रेस करेंगे, उसमें मीन वेलोसिटी, मीन ग्रेडियंट आएगा, पीक ग्रेडियंट आएगा, मीन वेलोसिटी और
What all you'll be trace once you trace the Doppler envelope? What all you will
Yes, sir.
get in that Doppler envelope?
सर मीन ग्रेडियंट, पीक ग्रेडियंट, VTI एट उस वॉल्व का VTI मिलेगा सर, और पीक वेलोसिटी, मीन वेलोसिटी.
All right, good. 2 important advantages of color flow mapping.
सर कलर फ्लो इसमें सर एक तो स्टेनोसिस रिगर्जिटेशन में सर इम्पोर्टेंट है, जिसमें सर उसमें वॉल बैक फ्लो आएगा, और स्टेनोटिक लीजन्स में भी कलर फ्लो हेल्प करेगा.
It tells you about the direction of blood flow. It
Direction
tells
of-
you
yes,
about turbulence.
यस सर, यस.
Last question. As per conventions, what determines the blood flow color on color flow mapping?
सर रेड कलर इंडिकेट्स की फ्लो टुवर्ड्स द प्रोब है, और ब्लू कलर इंडिकेट्स अवे फ्रॉम द प्रोब.
Good. This is known as BART. Blue away, red towards. All right.
Yes.
Let's move on to Dr. Tarun Goyal. Tarun, ready? Are the jets of mitral pulmonary regurgitation red or blue in color? Tarun. Dr. Tarun, are you there? All right. Dr. Tarun is absent. Next.
Hello? No, sir, I'm there, sir. I don't
Tarun,
know
I'm
what-
not able to hear you at all. Tarun, you have to concentrate. I'm not going to come back and mark you absent, you know.
Yes, sir. No, sir, I'm there, sir.
Switch over everything and concentrate on this. Either you
Yes,
can
sir.
see a movie or you can get into the question answer sessions.
No, I'm there, sir. Tell me, sir.
Tell me the jets flow in mitral and pulmonary regurgitation.
Sir, blue color, sir.
Mitral and pulmonic regurgitation.
Sir, it will be towards, I think it should be red, sir, because yeah, blue away red towards, sir.
Read the
go-
question properly. Are the jets of mitral and pulmonic regurgitation red or blue in color? I'm asking you a very simple question. I have not gone to basics of echocardiography as yet.
Yes, sir.
What will be the MR jet? Blue in color. Pulmonic regurgitation jet, red in color.
Okay.
Not reading at all. You know, how can you get a certificate from me? Tell me this question. What is Bernoulli's equation?
I don't know,
Tarun.
sir. I don't know, sir, about this.
From which structure the RA pressures are derived?
Superior vena cava and inferior vena cava, sir.
IVC, not superior vena cava. Never we have derived from superior vena cava.
Okay.
What is collapsibility index of measuring RA pressure? Anybody who's not happy, who's not comfortable with question can leave any time in between. What is collapsibility index of RA pressure measurements? No answer?
No answer. I don't know.
All right, last one for you. Name the echo window for interrogation of tricuspid regurgitation.
I pass on, sir.
All right, thank you. Let's move on to Dr. Amit. Amit, are you there?
Yes, sir.
Tell me the answer of this question. Name the echo windows for interrogation of tricuspid regurgitation.
Subcostal view.
We taught you 5 windows.
Sir, pardon?
We taught you 5 windows for interrogation or tricuspid regurgitation.
Sir, subcostal right para-external, supra-external and apical.
No, it's wrong. You can try again.
Sir, subcostal and right para-external.
There is no right pastral window for tricuspid regurgitation. Okay. Based on Doppler, what is the main criteria of increased pulmonary artery pressure?
Sir, velocity into pressure gradient.
Based on Doppler, what is the main criteria for increased pulmonary artery pressure?
Sir, I don't know.
Last for you. If the TR jet velocity is 5 meters per second, RA pressure is 10, what is the peak and mean pulmonary artery pressures?
4. 100 and 110.
What is peak and mean pulmonary artery pressure? You can correct your values. You are close by, but you're not correct.
Sir, 4 into velocity square.
There'll be 100. RA pressure is 10. Then what is the peak pulmonary artery pressure?
100 plus 10.
110.
Yes, sir.
Then what is the mean?
Mean is, sir, takes several pressures in one cardiac cycle. That is the mean of all peak pressures.
How do you calculate mean pulmonary artery pressure?
It is the we take 2 to 3 peak gradients in one cardiac cycle and average of that.
No,
is
it's
called
wrong. The mean pulmonary artery pressures are derived from peak. You add 0.6, multiply by 0.6, add 2.1. Amit, I'm telling you, look, you want a certificate for echocardiography
Yes, sir.
without knowing anything. This is basics, you know. I've not gone to basic true of echocardiography as yet.
Sir.
So once you drive peak pulmonary artery pressure, multiply by 0.6 and add 2.1, then you get a mean pulmonary artery pressure.
Ji, sir.
Last question for you.
Sir.
What are the important two-dimension features of pulmonary hypertension? Say yes or no.
Sir, no, sir.
Flat and D-shaped ventricle which bulges toward LV during systole.
Yes, sir.
All right. We go back to Abhishek now. Abhishek,
Yes, sir.
are you ready?
Yes, sir.
Important windows for interrogation or tricuspid regurgitation jet.
One is parasternal short axis view.
Right.
The other one is RARV inflow view.
Perfect.
Then there is apical four-chamber view.
Perfect.
Then there is a subcostal view.
Perfect.
And I can't remember the other ones.
Modified four-chamber view.
Modified.
Based on Doppler, what is the main criteria for increased pulmonary artery pressure? How do you drive pulmonary artery pressure from Doppler?
We put the sample from the TR sir.
Perfect. The next question was from that only.
And
Done. Nothing more than that. What information is obtained from Doppler signal of PRZ? Last question for you.
from Doppler signal of PRZ, we can derive mean pulmonary artery pressure and diastolic pulmonary artery pressure as well.
Perfect. God bless you. Great. I shift over to Sumit now.
Yes, sir.
Ideal scan plane for Doppler of mitral valve.
Ideal scan plane. Sir, 4-chamber view में करेंगे. The question नहीं समझा sir. Ideal scan.
Look at the word ideal scan plane to study Doppler of the mitral valve. There are two parts. One is 2D, second is Doppler. In which particular scan plane you will study the Dopplers of the mitral valve?
And plane.
Very simple question. Sumit is not a rocket science. When do you study the Dopplers of the mitral valve? In which planes do you study the Doppler of mitral valve?
Sir, plane ही समझ में नहीं आ रहा. 4-chamber apical.
अगर कोई आंसर का जवाब दे रहा है कूद के तो वो नेगेटिव मार्क्स उसको इनवाइट कर रहा है.
Ideal scan plane.
If somebody is trying to help, Abhishek is inviting negative marks for him.
Sir, 4-chamber view, apical 4-chamber view करेंगे उसमें sir.
It's very simple. You'll have to have apical 4-chamber view, 3-chamber view, and
उसमें
2-chamber
Doppler.
view. Doppler is parallel. Doppler is not perpendicular. My question
Yes,
is Doppler of the mitral valve. So it will be in 4-chamber view, 3-chamber view, or
Yes.
2-chamber view.
Sir, 2-chamber view.
Either of these views.
Yes, sir. तीनों में दिखेगा sir. वैसे तो.
Mitral valve.
But-
That's what I'm saying. Ideal scan plane, any 3 of them views.
Yes, sir. Yes, sir. I was not getting the questions. Sorry.
Okay. Where to keep a sample volume for? There are 4
Yes, sir.
choices are there over here. One on left hand side, second on right hand side.
Yes, sir.
The first matches to 1, 2, 3, 4, 5. Either of these 3. 6.
Where do you keep sample volume for? Sir, for mitral valve velocity, we'll put the sample volume at the tip of the mitral valve.
Okay.
In
Tricuspid valve.
सर ट्राइकस्पिड वॉल्व में भी सर वॉल्व के नीचे ही रखेंगे सर, जहां पे टिप नीचे आएगा.
Aortic valve.
एओर्टिक वॉल्व वेलोसिटी उसमें सर 5 चैम्बर व्यू वेंट्रिकल की साइड में, मतलब कंटिन्यूस वेव डॉपलर डाल के सर उसमें 1 to 2 सेंटीमीटर प्रॉक्सिमल डालेंगे.
And last question is, in LVOT, for calculating the LVOT velocity, where will
Yes,
you
sir.
keep the sample volume?
सर 1 to 2 सेंटीमीटर पहले रखेंगे सर एओर्टिक
Proximal
वॉल्व.
to aortic
एओर्टिक
valve.
वॉल्व.
Right.
यस सर.
All right. Name normal velocity of mitral valve.
सर mitral valve velocity 0.6 to 1 60 to 130 होगा, या 0.6 to 1.3 होगा. उसका हाफ हो जाएगा ट्राइकस्पिड वॉल्व 0.4 to 0.7. पल्मोनी एओर्टिक वॉल्व हो जाएगा सर 1 to 1.7, एंड पल्मोनरी वॉल्व उसका हाफ हो जाएगा 0.5 to
All right.
0.4 to 0.9.
Thank you, Sumit. Let's move on to Dr. Neha. Neha, what are the normal dimensions of LA? Neha, are you there?
Sorry, sir, I didn't unmute. Sorry. It is 34 ml per meter square index value.
Say it again, Neha.
34 ml per meter square, the index value, or 4. If you are asking about the area, then 4 centimeters square. 4
No,
centimeters.
normal dimensions of LA. Say it again.
Sir, volume is 34 ml per meter
No,
square is the index
normal
value.
dimensions. Here is, this is the dimensions of LA. What is the normal dimensions of LA?
So 4 centimeter.
4 centimeter. Absolute or indexed?
Absolute, sir.
Indexed?
Index is around 2.8.
2.2.
2.2. Sorry.
Okay. What is the normal LV size dimensions?
57 mm.
Absolute. And index?
Absolute. Index is around 38.
32. 22 and 32.
32.
When do you say the aorta is dilated?
More than 2 centimeters, 1.9 to 2 centimeters. If it is more than 2
Aorta.
centimeters,
What is the normal dimension of aorta?
so 1.9 to 2 centimeters. 1.9
Anything more than 26 millimeters or 2.6 centimeters. Last question for you, Neha.
Yes, sir.
Name windows where do we measure aortic flow velocities?
We can measure it in apical 3-chamber view.
Okay.
Then
6. Quick, don't have a time. We have to finish in 2 hours. Sir.
Yes, sir. Yes, sir. Apical 3-chamber view, suprasternal view. Then
This is very important because if you measure the aortic flow velocity, you have to tell in which particular window did you measure the aortic flow velocities, because so that the next person measures in the same.
yes, sir.
You will want to try again, Neha. You are doing good.
Sir, mostly we measure it in apical 3-chamber view. Then we see the
I'm not asking
suprasternal.
mostly. We have to do it all the times in all the 6 windows.
All yes, yes, sir.
Ravish, are you there? You can take up this question. Ravish? All right. The question is, in which windows? Let's start with Plaque's window. We can't see aorta in Plaque's window. Go to apical
No, sir.
window. 5-chamber and 3-chamber, right?
Yes, sir. Yes, sir. 5-chamber and 5 chamber.
Then go to subcostal window. Third,
No, we cannot.
we can. Once you open up the aorta and subcostal window, we can see a aortic flow velocity. Then fourth is right parasternal. Fifth is suprasternal. Sixth is right anterior oblique view.
Yes, sir.
There are total 6 windows, and in those 6 windows, we have to tell which particular window the highest velocity is recorded, so that the next
Yes.
person records that velocity automatically later on. All right.
Yes, sir.
So we'll stop. And one more question, if you can answer. What do you understand by peak velocity, peak gradient, mean velocity, mean gradient?
So peak velocity is the maximum velocity at the valve. Mean velocity is the average of various velocities, and similarly peak gradient and mean gradients are peak gradient is the maximum gradient which is obtained, and mean gradient is the average of multiple gradients.
All right, thank you. We move on to the next topic. We'll have a break for a few minutes. Let me open up a new topic and then. All right, let's go to Dr. Sumit again. Sumit,
Yes, sir. Yes, sir.
you have to tell me the wall motion abnormality in this subject.
Yes, sir.
We'll start
Sir.
view by view. 4 chamber.
Yes, sir. 4 by.
chamber,
Yes, sir. Yes, sir. Okay. In 4 chamber view, sir, mid and basal IVS is basal IVS is, sir, akinetic. It is thinned out, and mid IVS is hypokinetic. Rest lateral wall and apex is contracting normally.
Two-chamber
In 2
view.
chamber, yes, sir. In 2 chamber view, the anterior wall is moving normal, but in inferior wall, mid and basal inferior wall is hypokinetic. And in 3 chamber view, sir, it is normal.
So what coronary artery disease supply, coronary artery involvement would be there in this?
Sir, it will be RCA.
Okay. Anything else from this window? This is a bonus point. If you say that, you get certain extra marks.
Sir, aortic valve opening is not good. There is.
I'm talking of LV, wall thickening abnormalities, anything else. I'm not telling of walls.
Okay.
I'm talking of walls.
Wall.
Very subtle finding which is there in it.
Supply.
No. Now tell me anything specific you see in this.
Chorda thickening.
Something to do with the walls. दीवारों के साथ कुछ problem है.
Sir, calcification or thick.
Non-compaction of LV.
Flow आ रहा है sir.
No, non-compaction of LV. Look
Yes,
at this tuberculated, spongy myocardium.
Yes, sir.
This is seen over here very categorically.
Yes, sir. Yes, sir.
Okay.
Yes,
You
sir.
could not score this mark. There were additional mark. You had a chance to score additional. Anyway, let's move on to Dr. Tarun Goyal. Tarun, ready?
Yes, sir. Yes, sir. Yes, sir.
Okay. Look, I'm giving you a picture. I'll tell you the velocities and I'll give you the TR jet gradients. You can take down on a piece of paper. You can start writing it and then tell me what kind of a diastolic dysfunction it is. We have E and A wave. E wave is 44, A wave is 83, ratio is 53. And this is a normal LV systolic function. Same patient where we had an almost normal ejection fraction. So ratio is 53. E prime septal is 5. E prime lateral is 7. LA volume is 44.6. And the TR jet gradient is almost 3 meters per second. So in which category this diastolic dysfunction is?
Is it LV diastolic function?
Speak loudly, Tarun. I can't hear you.
Sir, likely LV diastolic function, sir.
What category of LV diastolic function it is? I hope you understand what I am asking you, Tarun.
Yes, sir. Yes, sir. Category, you mean like probably
Do you know about diastolic function abnormalities, variety, grading?
not really. No, I've just gone through, sir. I don't remember completely right now.
All right. You want to take this question, or I should give it to somebody else?
Give it to somebody else, sir. Thank you.
Okay, I'll move on. Let's give this question to Dr. Amit. Amit, Amit,
Yes,
are
sir.
you ready?
Yes, sir.
Velocity ratio is 0.53. E prime septal is 5. E prime lateral is 7. Then we get a LA volume of 46.6 ml and TR jet velocity of 3 meters per second.
Yes, sir.
Variety of diastolic dysfunction. Here all the values are there.
Mild to moderate.
Amit, I understand what you're telling me the answer. Tarun, what
Yes, sir.
Tarun could not answer it. Amit, I hope you understand what I'm asking you the question. There cannot be mild, there cannot be
Sir, mild
moderate.
diastolic dysfunction.
Tarun, this is not the
Can I
right
take?
answer.
Can I take, sir?
Sir, Tarun is there,
Just
sir.
give me a time. I'll give you come back again. Dr. Abhishek,
Sir, it's grade 2 diastolic dysfunction
and
with elevated LV filling pressure.
with
And
elevated LA volumes.
LA
Here
volumes.
is the comparison. So this is 53. So this classifies into this categories, right? EA ratio. Then EA prime average is less than 10. LA volume is 46. TRZ gradient is 3. So it classifies into grade 1 diastolic dysfunction with raised LA volumes. Abhishek, you are good, but you have to perfect yourself.
Okay, sir.
And this is in normal patients. What do you mean by grade 1 diastolic dysfunction? Like what LA pressure are we expect in this patients? What LA pressure do we expect?
In grade 1, usually the LA pressures are normal,
Borderline elevated.
borderline.
Normal LA pressures are
Normal
8 to 10.
8 to 10 years.
All right. Sumit,
Yes, sir.
wall motion abnormalities.
Sir, IVS is akinetic with thinned mid and basal mid and apical IVS, and the lateral wall is also thinned out with
Sumit, I want an answer like basal IVS, basal septum, mid septum,
basal and
septum.
yes, sir. In fourth chamber in mid and basal is hypokinetic with apical akinetic, apex is akinetic, lateral wall apex and mid is akinetic, and the basal is hypokinetic.
Now two chamber view.
Sir. in two chamber, anterior wall is moving, contracting normally, but inferior wall is, so patient same hai, alag hai?
Same patient. Look at timers are over there. 15/7/22, 12:34. 15/7/22, 12:34. 15/7/22, 12:34. At 00 PM, 34 seconds, 12 seconds.
Yes, sir. Sir, inferior wall is hypokinetic, sir. Whole inferior wall, or anterior wall. Hello, sir.
Yeah, Sumit. Finish it up quickly, Sumit.
Yes, sir. Sir, inferior wall hypokinetic hai, sir.
Whatever
two
you
chamber
saw,
given.
it which category it belongs to? Which territory of coronary disease will belong to?
Sir, LAD territory mostly.
Why the inferior wall is involved?
Inferior wall hypokinetic है sir, akinetic नहीं है. But
अगर hypo भी है तो क्यों है? Good answer. I'm not saying you are correct to a large extent. Because when we have a type 3 LAD, it wraps around the apex and supplies inferior wall.
Yes, sir. Yes, anatomically.
Okay. Ejection fraction?
Sir, I guess 15 to 20%.
No, it's about 40%, 38 to 40%.
38.
All right. We move on to Neha. Neha, are you ready?
Yes, sir.
So this is reduced ejection fraction, Neha.
Yes.
So I want to categorize you to calculate diastolic function for this reduced ejection fraction. You have got all the velocities, E wave 129, A wave 87, ratio 1.47, PR jet velocity 2.29, PR gradient 21. So what category of diastolic dysfunction it will be? And the volume is E prime septal 5, lateral 7, wall E2 prime average is 21.5, volume is 44.61 ml.
So the previous slide, can I see the previous slide?
Sure. You can write down on a piece of paper and I'll give you 1 or 2 minutes. You have to tell me what kind of a diastolic function it is.
With type 2, sir, type 2 diastolic dysfunction.
I'm talking of reduced ejection fraction. So look at your values now. Ratio E and A. E wave is, in this ratio is E and A. So it's neither 1 nor 3.
Right. Yes, sir.
Then E
Grade
ratio
2,
is
that's
1.47. E prime septal ratio is average is 21.5. So more than 14. PR jet velocity 2.29 less. PR jet gradient 21. LA volume was 46. So 2 out of 3 are positive. So once 2 out of 3 are positive, we call them as grade 2 diastolic dysfunction.
Yes, sir. I told grade 2 only, sir.
Okay. But you did not tell raised LA pressures.
Yes.
All right. So we'll break it over here and we'll come back to next set of questions. Just hold on for a few minutes. All right, let's start again.
Yes, sir.
The first question goes to Dr. Sumit.
Yes, sir.
What is the abnormality?
Sir, mitral regurgitation is there, and sir MR है sir, बाकी तो नहीं दिख रहा है.
Spend time. It's not pure MR, man.
MR with MST. So tricuspid regurgitation is also there.
Anything else? Okay, I'll give you a clue. Patient
Yes,
has
sir.
got irregular rhythm. Now some findings
Yeah.
on two-dimensional echo.
Sir, can I take this?
Oh, wait a minute, Neha, I'll come back to you.
So if
Let me give it up. Do you see something different in this window? It's very categorically seen. You know, that is the clue for any doing echo.
sir motion, heart motion हो रहा है sir, heart movement,
May I take it, sir?
fusion.
May I take it?
सर RV जो proximal RV OT है सर dilated है.
Okay, Neha, go ahead.
Sir, may I
Is
take
it the arrhythmogenic right ventricle?
No, Neha, wrong.
Sir, can I take it, sir? Tarun this side.
Tarun, go ahead, go ahead.
Can I take
Is it mitral stenosis, sir? Sir,
Wrong.
MVP? Mitral valve prolapse, sir.
Wrong.
सर RV dilated है सर flex view में.
Wrong. अगर आपको नहीं आता तो don't take it. You're getting a negative marking out of this.
Sorry sir.
That's why I'm saying, if you know, then only you jump. A patient who has got a
सर
irregular,
atrial septal.
patient who has got irregular rhythm, what will happen? This is the case of atrial fibrillation.
Yes sir.
Look at this ECG, atrial fibrillation. The only E wave is present, A wave is not seen.
Yes sir.
When you have an atrial fibrillation, what will happen? You will get both mitral and tricuspid regurgitation. On top
Yes,
of
sir.
that, your LV and RV would be normal, LA and RA would be dilated. Look at the huge RA. RA is almost bigger than LA.
Yes sir. Yes sir.
If you have been vigilant, you could have asked me, what is the ECG finding of this patient?
Yes sir.
And for arrhythmogenic RV, you have to have really trabeculated RV over here.
Mm.
This is not trabeculated RV. Okay, so this is a classical finding of patients in atrial fibrillation. So you have scored almost 0, Sumit. Tarun,
Yes,
you
sir.
jumped in between, again marked 0.
Okay, sir.
सर AF भी बोला था मैं.
ये
Sorry,
लास्ट में बोला था, फाइंडिंग्स नहीं बोला, वो तो मैंने बोला था.
Sorry sir.
फाइंडिंग्स मैंने बोला, मेरे को एको का फाइंडिंग चाहिए, एफ थोड़ी चाहिए.
सर regurgitation था सर उसमें. Sorry sir.
Regurgitation है, but you have to have a dilated LA, dilated RA, normal
Yes.
LV, normal RV. Then only we'll have an algorithm.
Sir.
All right, Tarun,
Yes, sir.
tell me the abnormality. I've told you half of them. What all I'm looking forward? What is this? What this pattern is known as?
Sir, ECG shows atrial fibrillation. That's the only thing I can see here.
No, I'm not asking atrial fibrillation. Atrial fibrillation is interpretation. What all pattern is seen in this? This is mitral flow pattern, right? So what I'm looking in mitral flow pattern? I said I'm only looking at E wave. There is no A wave. What is this modality known as? Tarun, are you there? You're lost.
I'm there. No, I'm there, sir.
What is this modality? All right. So what is this modality? No answer, Tarun?
No, sir.
All right. Dr. Amit, would like to take up this question?
Yes, sir.
Go ahead.
Sir, first is pulsed wave Doppler, second is A mod, and third is continuous wave Doppler.
What is second?
A mod, sir.
Pardon?
A mod.
M mode of what?
Color. Color.
Color what?
Color.
Color?
Eye scan.
Pardon?
A mod eye scan.
M mode?
Eye scan.
Now. What is this modality, Amit?
Continuous Doppler.
This modality is continuous wave Doppler. And this?
Yes, sir. Sir, both are continuous.
Amit, read, man, read, man, read.
Sir.
Out of 4 questions I have asked you, Amit and Tarun, one questions Tarun has got 2/4. Rest all of them are nil. Amit has only asked 2 questions. There are 3/4 and 2/4. Rest of them all are 0. This is tissue Doppler imaging.
सर मुझे पता था ये.
All right, let's go to Abhishek. Abhishek, you would like to try?
Yes, sir. The first one being the pulse wave Doppler tracing. I mean the signal. The second one is color M mode propagation.
Perfect. Go ahead. Third.
Third one is tissue Doppler of the medial annulus. I mean the septum.
All right.
And I think the last one is also tissue Doppler imaging of the medial septum.
Perfect.
I mean the septum.
And now I want to know, like, suppose a patient or atrial fibrillation is there, how will you calculate his diastolic function?
Calculation of diastolic function in atrial fibrillation. We can calculate by this isovolumic relaxation time.
One
is that. Another is you can calculate by this ratio E and color M mode propagation velocity.
Ratio of what?
The E velocity and
okay.
Color M mode propagation velocity.
Third.
And third, I can't remember the third one.
E to E prime average.
E to E prime average.
So we use 3 modalities in day-to-day practice. One is E to E prime septal, E to E prime septal ratio, not the average. Second is EVP ratio, and third is IVRT. If E to E prime septal ratio is more than 11, EVP more than 2.5, and the IVRT less than 65 milliseconds, we call them as elevated LVDP in atrial fibrillation.
Yes, sir.
Okay.
Yes, sir.
All right. Let's move to Sumit.
Yes,
Sumit?
sir. Yes, sir.
Answer.
Sir, left ventricle is dilated with mid and basal septum is akinetic. Rest is rest LV is spongy. Or so dilated LV.
All right. Fair enough. Neha.
Yes, sir.
Answer. Neha, go ahead, quick. You have to respond fast. There are 2 images seen in front of you. Tell me what is the abnormality in this patient. Very simple. They are not rocket science in this.
So MR.
Neha,
So mitral regurgitation.
you were doing very good, Neha. Don't disappoint me. Okay, I'll give you a clue.
So yes, sir, please.
Something disproportionate in walls.
So severe MR because of.
All right, severe MR is there, but what else?
So we need to calculate the vena contracta for the severe MR.
Oh, I'm not asking you vena contracta, Neha. I'm asking you basic things. Vena contracta lasts from level 2 in the evening.
So
Neha,
prolapsed mitral.
look at the septum, look at the posterior wall.
Yes, sir, sir. The septum is hypertrophied, sir.
What else now? There is
The
mitral
HOC
annular calcification is present.
Yes, yes, sir.
During systole, something is going towards.
Mitral stenosis, sir. Mitral stenosis. Sorry. Sorry, HOCM, sir. I mean, this is a systolic anterior motion in case of hypertrophic cardiomyopathy.
Asymmetrical septal hypertrophy.
Yes, sir. Yes, sir.
Neha,
Sorry.
I'm sorry.
Sorry, sir.
Don't disappoint us, like you.
Yes, sir, sir. Septal
All
hypertrophy
of you,
leading
like,
to.
you are one of them who really do good. Abhishek is really good. Abhishek has really learned the lesson, no doubt about it. I must appreciate Abhishek.
So actually, I was just looking at the valves. I just didn't see the septum and the posterior wall.
Okay, I'll give an opportunity.
Sorry, sir.
Now tell me what's there in it.
Again, this is the systolic anterior motion because in a case of HOCM.
Correct.
Pardon me, sir?
Correct. Now what is the abnormality?
So LV is hypertrophied, extremely hypertrophic.
Same patient, Neha. Look at the septum, look at the posterior wall. Is almost 1.5 to 2 times of the posterior wall.
Posterior wall, yes, sir.
And what is another abnormality is LV function. What is the LV function would be?
So supradynamic.
Almost like very high.
Very high
fraction,
ejection fraction. Yes, sir.
which is abnormal, which is not normal.
Yes, sir. Yes, sir.
Okay.
Yes.
So keep it up. You lost a couple of points in this.
Sorry, sir. Sorry.
Okay, we come back again to Sumit.
Yes, sir.
Identify the abnormality, Sumit.
Sir, this is 3-chambered view with sir, turbulence is there in mid cavity, I think.
Perfect. Very
Gradient, sir, gradient भी sir, gradient ज्यादा है sir mid में.
नहीं, continuous wave Doppler लगाया मैंने यहाँ पर, देखो आपके सामने continuous wave Doppler है.
Yes, sir. नहीं, gradient sir, मतलब जो ग्राफ है सर ठीक नहीं है. Sorry.
Pardon?
ग्राफ सर ठीक नहीं आ रहा है, मतलब बीच में सर टर्बुलेंस है जिसके कारण से सर.
Correct. This is mid cavity gradients.
Yes,
which
sir.
are not significant. Is almost 1.5 to 2 meters of flow velocity, and this is dynamic LVOT obstacle. Dynamic flow, not obstacle, dynamic.
Yes. Flow. Yes, sir.
Okay. One more to you before we move on to next person. Now tell me what's happening, Sumit.
Sir.
Sumit, you are also good. It's not that you are the bad. You are good.
Yes, sir. Sir,
I'm
left side.
disappointed by only 2 people, Amit and Tarun.
Sir, इसमें mitral valve sir cross कर रहे. Sir, mitral valve.
This is known as caudal SAM.
caudal. Yes, sir.
Okay.
Yes, sir. Caudal jam.
All right. Let's move to Tarun. Tarun,
Yes,
you have
sir.
a chance to upgrade yourself now.
Yes, sir. Thank you.
What is the abnormality, Tarun?
Looks like mitral regurgitation, sir.
Look carefully, Tarun. Don't disappoint me. Where is mitral regurgitation, Tarun? Okay. This is three-chamber view. This is a
Yes, sir.
Doppler flow pattern across three-chamber view.
Yes, sir. That's right.
Tell me the importance of this Doppler flow pattern in three-chamber view. Tarun, these are basic questions, you know, like once you see these patients in echocardiography, if you happen to miss them,
Yes, sir.
they really make a lot of sense, you know, because that is the practice is dependent on.
Yes, sir.
Anyway, Amit, you would like to take up this question?
Sir, MS and PA pressure high.
Amit, this is three-chamber view, beta. This is a continuous wave Doppler across three-chamber view. LV, this is LA is over here, aorta is over here, so it's a Doppler flow across aorta. What kind of a Doppler flow it is? You can concentrate on this, they'll give you much better information. No?
No, sir.
All right, Abhishek.
But there is turbulence in the LV cavity, distal to. I mean, there are lots of turbulence, so there should be some obstruction in the LVOT.
Correct, correct. So can you explain this Doppler flow pattern, Abhishek?
So is it, I don't know, is it dagger shaped or, I mean, the
This is dragger shape. Look, this is
Dragger.
two flow patterns are present. One is aortic flow and this is dragger shape. Long acceleration time. This is very long acceleration time which is present over here. So this patient has got LVOT obstruction leading rise to almost 3 meters of the flow velocity. Good.
Yes.
So Sumit, that's done. And we'll move on to now. Abhishek is done. Sumit is done. We come to Neha. Neha, last question before we move on to another subject.
Yes.
So get ready, Neha.
Yes, sir.
So give me a sec. I'll get back to new question set.
Okay.
All right, Neha, you got a very simple question. Very simple. You are lucky. What are we measuring?
So array dimensions.
Tell me the dimensions of RA.
So as in normal dimension you are asking, sir?
Yes, normal dimensions.
So we measure it first at the annular diameter we measure. Then we
First
measure
measure
a
during
septal.
diastole, we
Yes.
measure the annulus of tricuspid valve.
Yes, tricuspid valve annulus we measure. Then we draw a perpendicular line from the which is parallel to the atrial septum. Yes. and then a line perpendicular to that at the maximum RA diameter.
At the maximum or in the center of RA?
In the center, which is perpendicular to the previous line.
Correct. So what is the normal size of RA?
So 2.8 centimeter.
We do get two kinds of an RA size. One is a long axis, one is a short axis, then RA volume, and they are indexed values. Okay?
Yes, sir. They are gender specific and
Yes. So the RA dimensions are 46 into 40, 25 into 19 millimeters per meter body surface area.
Yes, sir.
And similarly, we measure RV dimensions. How do you measure RV dimensions?
It's the same two horizontal dimension and one vertical, and again the annular dimension we measure, then one at the tip of the mitral tricuspid leaflet, and a line perpendicular which measures the longitudinal.
Okay, just a second. All right, Neha, comfortable. Let's move on to the next Dr. Sumit again. Sumit, are you ready?
Yes, sir.
What is the abnormality, Sumit, in this patient?
Sir, RV is dilated more than the LV, and R pulled, मतलब सर RV apex भी सर नीचे पुल किया हुआ है और dilated है और trabecular मतलब smooth surface नहीं है सर.
What else?
RA भी dilated है सर.
Let's focus on RV. Something more in RV.
सर septum भी thinned out septum है और
Okay.
RV wall
Or a little tough
Pulled
question
out,
for you. I do agree with you. This is RV. This is pericardial effusion.
pericardial effusion.
And this is hypokinetic mid and basal RV free wall.
Yes sir. वो fluid लग रहा था सर वो pericardial effusion. ठीक.
All right. Let's move on to Tarun. Tarun.
Yes, sir. Yes, I'm there.
Tell me what is the abnormality, Tarun?
Sir, RA dilatation is there.
Okay. RA, RV.
Sir, RA is dilated.
RA is dilated. Okay. What else, Tarun?
Septal thinning is there. Interventricular septal thinning. I can
Okay.
see.
What else is there? Tarun is a very classical picture, you know, like you just can't forget this picture once you see it. What happened to LVLA? They have been
It's
chinked out.
collapsed. Yeah, shinked out, sir. Yeah,
Chinked out. You know, like they are huge dilated RVRA. There is a pericardial effusion along with it. In which condition do you expect these kind of findings? Where do you expect this kind of
cardiac tamponade was.
cardiac tamponade? Cardiac tamponade would be everything would be in the shell, you know.
Yeah.
Tarun, I'm sorry. Where do you practice, Tarun?
So I have practiced in Vasundhara and Vaishali, Ghaziabad.
Full timer, part timer?
No, full time.
Full time. Okay. Let's move on from Tarun to Amit. Amit,
Sir, RV dilated, LV side is collapsed.
Pardon?
RV dilated.
Okay.
I think, sir, this condition is seen in core pulmonary.
Good. Anything else? Acute versus chronic.
Sir, chronic in core, acute in pulmonary embolism.
Good. And in today's circumstances, and for last 2 years, could you correlate this condition?
With COVID.
COVID. Good.
Yes, sir.
But this is acute or chronic?
Sir, it is looking like acute.
In acute, what will dilate, RV or RA?
Sir, both, but RA will dilate more.
RV will dilate first, then RA, but both can dilate. And this, what is this?
Sir, which one? Sir,
Here,
which one?
my arrow. Here.
Inferior vena cava.
Now you can see a picture again, and my arrow is pointing over there. Pericardial effusion, man.
Yes, sir. Pericardial.
If a patient of pulmonary embolism develops pericardial effusion, good prognosis, bad prognosis.
Bad prognosis.
All right. Let's move to Abhishek. Abhishek, it's all yours. Tell me the abnormality.
Yes, sir. There is the septum seems to be thickened along with the posterior wall, and there is some pericardial effusion as well, and there is increased echogenicity as well. So probably this may be amyloidosis, the pathology.
Oh, great, man. God bless you.
Thank you, sir.
Look, everything is brightened. If you look at this picture, everything is so brightened and thickened that you cannot forget this picture ever once you see it. Abhishek, tell me a condition where there's no amyloidosis, but you find this kind of a picture. That's a bonus. If it all depends whether you want to reply or you don't want to reply.
Mm-hmm.
Do you think any condition?
Is it this endomyocardial fibrosis?
No.
No.
This is chronic kidney disease.
CKD, yes.
CKD will also give you something like this picture. I'm sure you are pretty young. You have not seen Maconis Gold. Try to see Maconis Gold. You know, like when those Gregory Peck is sitting on top of a valley,
yes,
and they are sitting there in the night. When the sun brightens up, the light falls on the valley of diamonds. You know, everything brightens up. That's a picture of 1970s. You know, not today's. Like once you look at this echo, look, everything appears to be so thickened and bright, you cannot miss it. Great, good job done, Abhishek.
Thank you.
All right, Nehaji, it's for you.
Yes, sir.
Don't disappoint me this time. Neha,
Yes, sir.
go ahead, quick. One more round and then we are finished today.
So this is the parasternal short axis view.
I'm not asking you parasternal short axis view. I know you know about it.
So I can see a echogenic shadow in between the left ventricular wall.
All right. There is something unique in this picture.
It's a D-shaped cavity. The
Great. Now tell me whether the RV pressure is more than LV pressure or LV pressures are more than RV pressure.
RV pressure is more than the LV.
Why?
The interventricular septum is bulging towards LV during systolic.
Done. Good job done there.
Thank you, sir. Thank
Okay, we go back to Sumit again. Sumit,
Yes, sir.
tell me abnormality.
सर शॉर्ट एक्सिस व्यू है सर, माइटल वॉल इधर से ट्राइकस्पिड रिगर्जिटेशन है, पेरिकार्डियल इफ्यूजन है
और
डायलेटेड है सर, RARV.
good. What else? You are close, Sumit. Very good. You are very close to everything. Just one more finding you are done.
सर हिंट
Hint is previous slide.
पल्मोनरी
Neha answered the previous
सर
slide.
प्रेशर RA प्रेशर मोर देन
Correct. Good.
कंप्रेशन हो रहा सर.
Look, it's dilated RVRA with
Yes, sir.
interventricular septum bulging
वो
towards
शिफ्ट हो रहा है सर,
ventricle,
पुश हो रहा है.
normal mitral valve, and then you have a tricuspid regurgitation seen over here. What else you want, you know? This is a highly pressure overloaded light condition.
Yes sir, pressure overload.
And the patient has got a pericardial effusion also, as you said already.
Yes sir.
Again, it comes to in which condition do you see all this? Look, this is same slide of the patient. We have a TRZ gradient which you can measure is almost 46.
Sir.
It must be more. And now give me the answer. Am I correct that I'm measuring the TRZ velocity gradient as only 46? How can I really get the true TRZ gradients? Is bonus, it all depends on you want to reply or you don't want to reply.
Sir, question समझ में नहीं आया.
I'm getting a TRZ gradient of only 46.
Yes sir.
Maybe 60 or 50. But looking at this picture, am I right or wrong?
Sir, ज़्यादा होना चाहिए.
ज़्यादा होना चाहिए.
Yes sir.
Then how do you get your how do you get your PA pressures? Some clinical finding will tell you how much your PA pressure should be.
सर क्लिनिकल फाइंडिंग में सर फिर नेक वेन डायलेटेड होगा.
अगर आप बीपी रिकॉर्ड करोगे तो आपको पता लग जाएगा टीआरजेड ग्रेडियंट कितने होने चाहिए. You said your RV pressure is more than your LV pressures.
Yes.
Correct. LV pressure is what?
जितना हाँ BP
your
होगा.
blood pressure. So if your
उससे
blood
ज़्यादा होगा
pressure
तभी वो
is 110
compress हो रहा है.
millimeters of mercury, the RV
Yes.
pressure has to be more than 110 millimeters of mercury.
Yes sir. Yes sir.
Correct.
Yes sir.
Suppose I'm not getting 110 millimeters of mercury. Now what do you do to drive your best TRZ gradients? Tarun, like to take
Yes,
up this question? Tarun, are you there?
I'm there, sir. I'm here.
Answer. Shall I pass on?
Yes, sir.
Amit?
ये सब पास कर दो.
Abhishek?
Sure, it should be, I mean, the wave should be perfectly aligned with the Doppler, color Doppler.
Abhishek, I'll say it again. If I'm not able to get in this window the TRZ gradients, how can I really improve my TRZ gradients?
I'm afraid, sir, I can't.
All right. Then we Neha.
Sir, actually TR jets are more dependent on RV pressures. So we should not measure TR jet in such patients. We can measure either the TAPSE or TIE index. PR pressure. We should measure the TIE index.
TAPSE and TIE index will tell you systolic function, not the TRZ gradients. The simple answer is, if you are not getting in this window is
So
If you're
SD
not,
ratio in the pulmonary veins.
no, if you're not getting in this window, you look for other 4 windows. We are only looking at one window. We said we need 5
Yes, sir.
windows to look for a TRZ gradients. If I'm
RARB
measuring
focus
only
view.
Yes,
50 to 60 in this, so I should go to other windows to look for my TRZ gradients.
Yes, focus view.
Or else you should go to parasemic short axis view at aorta, look for a PRZ. If it's possible,
PRZ. Yes.
then PRZ mean velocity will give you the answers of your mean pulmonary artery pressures. You did said PRZ. I'm not saying no. You did said, but the correct answer is you should go to other windows to evaluate your TRZ gradients. We never said my RV is hypokinetic. Did we ever said this? My RV is hypokinetic. I never said my RV is hypokinetic.
So your voice was breaking. I didn't get what you said.
All right. So we come back again. This question comes back to Sumit. Sumit, what are we looking for?
Sir, this is short axis view. Sir, pulmonary regurgitation है, उसको देख रहे हैं sir.
Okay. And what left hand side, what we are getting it?
Sir, positive shift है PR.
Okay.
PR gradient ही
What
आएगा.
I am measuring over here?
Sir, late diastolic pressure, sir.
Late diastolic pressure reflects what?
RV pressure. Late.
You can try it again.
Pulmonary artery pressure.
You can try it again. Last try. No?
Sorry, sir.
Tarun?
No, sir. Pass.
Unfortunately, Tarun, you always get a wrong question. Wrong time your number comes. You know? Unfortunate. Tarun, what do you measure this? Pass on, Tarun.
Yes, pass on, sir.
Amit? Amit, are you there?
Pulmonary regurgitation.
Speak loudly, Amit. Tarun. Amit?
Sir, it is pulmonary regurgitation.
No, it is pulmonary regurgitation. If I'm measuring this pressure over here, what I'm measuring? What does
Sir,
this value
end
give me?
diastolic pressure in late heart failure. Heart failure.
Pardon?
End diastolic pressure.
And diastolic pressure means what?
Heart failure, sir. It indicates heart failure.
Heart failure.
Yes.
In our heart, there's left atrial pressure, left ventricular pressure, right atrial pressure, right ventricular pressure. So what is this pressure is?
So mean pressure.
Okay, Abhishek.
Sir, this when you measure the velocity at the end diastole, it measures your diastolic pulmonary artery pressure.
Sir, it indicates.
Artery pressure
Sir,
is
may I
what
check?
family, man?
Sir, ischemic heart disease.
This is measuring of LA mean pressures. Where this ultimately reflects to?
The pulmonary capillary wedge pressure, LMN
Correct.
pressure. Pulmonary capillary wedge pressure.
So what we evaluate from a diastolic function, we evaluate from a TRZ the same thing, PRZ the same thing. Only fact is there should not be any lung condition or lung abnormalities in this patient. Okay. Tarun, I'll give you a smaller one, simple one. Try this. Now instead of measuring the last, I'm measuring the first one.
Okay, sir.
Tarun,
Yes, sir, I'm there.
what does this value tell you? Pass?
Yes, sir. Pass.
All right,
Pass,
Amit.
sir.
Sir, pass, sir.
Okay, Sumit. Sumit, you want to try this question?
Sir, अर्ली डायस्टोलिक सर ग्रेडियंट पीआर में अर्ली डायस्टोलिक को सर मेजर कर रहे हैं और मीन सर पल्मोनरी आर्टरी प्रेशर बताएगा सर.
What pulmonary artery pressure? Peak, mean, average, or
मीन बताएगा.
perfect? How will you tell your mean pressure? Suppose this is a gradient of 40. So what is the mean pulmonary artery pressure in this?
उसमें सर मीन 0.6 into
No. This is already giving you mean. Why 0.6? Abhishek?
Sir, we'll multiply the velocity into 4 and we add the RA pressure.
We add RA pressure to it. Suppose this is 41, 40.95, so say 41. You add RA pressure from IVC. If it's 5, it becomes 46 mean pulmonary artery pressure. Severely elevated. Right, Sumit?
Yes, sir.
Okay. Abhishek, question for you. Diastolic function in this particular slide. RV diastolic function.
Sir, I didn't get it, sir. What should I say?
What is the RV diastolic function in this slide? This is the Doppler flow across tricuspid valve. Here is mitral, this is tricuspid. So this is tricuspid Doppler flow. This is E wave is 0.64, A wave is 0.27, 2.35 is the EA ratio. Distillation time is 137 milliseconds.
I'm sorry, I have not studied this, sir.
You are not studied. Neha?
Sir, then E by A ratio will.
All right, I'll pass it on.
E by E prime will calculate.
No,
For that.
this is known as type elevated RVEDP, grade 3 diastolic dysfunction. EA ratio is more than 2. Distillation time is less than 140 milliseconds, which is known as elevated RVEDP. As we have left-sided elevated LVEDP, we have the same thing on right side also. I'm not going to give any marks to anybody. I'm not going to cut any marks from anybody. All right. Abhishek, coming back to you, last few set of questions. What is this modality?
Sir, this is spectral tracking echocardiography. And we look at the longitudinal strains.
We look at what?
We look at the strain.
Okay.
Strain pattern.
All right. Can you identify the strain pattern of this patient? Very classical.
I mean, the normal should be, I mean, the more the negative, the more normal it is, the less the negative.
Right. It's a little tough question for you. Not at your level. I agree with you. Neha, you want to try?
So it is the strain pattern is around -8, which is much less than -20. So severely strained LV.
Yes.
Okay.
सर नीचे ग्राफ जाएगा तो नॉर्मल रहेगा ना वो तो.
This graph is down is normal. This graph up is abnormal.
Yes sir. इसमें सर मिड और बेसल. Yes sir. Mid and basal part जो रहेगा वो
segment shows positive deformation.
Is abnormal.
Segment shows negative deformation. But
that is
even this is low.
Even this is low. Everything is low, but the upper two are severely strained, and the last the green light.
The word is not severely strained. They show positive deformation. It means when RV is contracting, the upper segment is coming inside, the lower segments are going outside. And to a large extent, if I say this is apical sparing is present, mid and basal segments are less contracting, it means what? It means that you remember that phenomena of apical sparing with mid and basal segments being abnormal or reduced contraction, McConnell signs. This is true depiction of mechanism sign, although this apical part is reduced in contraction. But this is sometimes seen in people who have got pulmonary embolisms where the apical strain is positive. That means shows negative deflection. Mid and basal segment shows relaxation when apex is contracted. That is an advanced stage for right side pulmonary embolism or advanced stage of pulmonary embolisms. I'm not going to say good or bad, like it's good, like whatever it is. All right. Neha, for you.
Yes, sir. Identify
Don't
the
tell me this is ARVC.
RV function.
This is not
Arrhythmogenic right
ARVC.
ventricle.
Yeah. Reduced, normal or abnormal?
So your voice is breaking. I just didn't hear the next question. Hello.
The function is
Hello.
normal or abnormal?
So it is dilated. It is abnormal.
Abnormal is reduced, right?
Yes. Yes.
This is for you. Last questions, Abhishek.
Yes, sir.
Identify the abnormality. If you identify the abnormality, something good.
Hmm.
Neha, Sumit, you can take up these questions.
Is there
Bicuspid
Sir, can I take, sir?
Yeah, go ahead.
RVOT?
Sir,
So is there a
इसमें सर
bicuspid
LA
aortic valve?
में सर मास है,
RVOT of
LA में सर क्लॉट है जो शॉर्ट एक्सिस में, उसको कंफर्मेशन के लिए सर अपेंडेज में देखेंगे.
मुश्किल लगाने आ रही है. I'll tell you like
Sir,
it's little difficult
mass-
for you. This is short axis
से
view of
सर
aorta.
क्लॉट या मास पूछे.
This is LA appendage mass, which is
Yes,
placed
sir.
over here, and this is LA mass. Look at
Yes,
the LA
sir.
mass
Yes,
over here.
Yes, sir.
And this is a patient which we just scanned a few months back. It was pulmonary. It was endocardial tuberculosis. It's an endomyocardial tuberculosis. Previously, the masses was huge, and now they have disappeared to a large extent. They are only seen in this picture over here and this picture over here. Okay.
Yes, sir.
So how is it
Yes,
confirmed that it is
How it's
tuberculosis?
confirmed? Neha, it's a big time. Like we deliberated,
Okay, sir. No issue.
couple of us sat down together.
No, I mean-
deliberated.
I mean, I just want to ask from the imaging itself, or is there any other modality?
No,
that-
like we did the imaging first, then we scanned up, we looked at patient, CT, MRI, CT scan chest and MRI, cardiac MRI.
Okay.
And then we had abdominal CT scan. Then we had one of the biopsy of the abdominal glands. And that's how we
Okay.
came to know is a disseminated tuberculosis. So we gave empirical ATT along with steroid for this patient, about 17-year-old boy. And
Oh,
over a period of all these masses, they disappeared. So our presumptive diagnosis is tuberculosis.
okay, sir.
All right. Let me just stop it over here. I'm
Yes,
fine,
sir.
comfortable. I'm not going to ask you much questions now. I'll stop over here my recordings and everything. And thank you very much for your patience part on this particular phenomena. And let me just stop it and then I'll talk to you a few more things. And before